Hi, it's Dr. Centeno, and thanks so much for joining me today. Got an interesting subject in keeping with the theme of the last couple of weeks where I've been going through, do you have this diagnosis or CCI? Today we're going to do migraine headache. So do you have migraine headache or headaches coming from CCI? This is a big one because I can't tell you how many patients walk into my office and state that they have a migraine headache when there really isn't much evidence that they have a migraine headache, meaning that I think most patients view migraine as a catch-all term for headache. It's not. Migraine is a very specific type of headache that has really nothing to do with the kind of headaches that you would get if you had a neck problem. Those would be cervicogenic headaches. So since this is such a common thing that happens where people walk in and say, my doctor, I have migraine headaches and I might have CCI, I want to differentiate those two so that people could understand that there is a difference. Again, after that, I'll answer questions. If you have specific questions about what we're talking about, that's great. If you want to ask anything about anything at all, that's great. So it's really an AMA type format. Ask me anything, preferably having something to do with regenerative medicine or craniocervical instability or PICL or other types of procedures in that family. So let's see here. Let me go and share my screen here. And we'll get started. So again, the topic today is, do you have a migraine headache or craniocervical instability? And again, I get patients that really walk in confused about this. So I thought it was time that we spent a little bit of energy focusing on this topic. So I want you to like, comment, share, and subscribe because that's how we get this information out to other patients. So if you want to pay it forward into the CCI community, then take a second right now, whatever platform you're on. We're on YouTube and two Facebook channels right now. Like, comment, share, and subscribe so that we can get this information out to more patients like you, because that's how they find it. If you don't do those things, they can't find it in the either YouTube or Facebook algorithm. And I just want to let everyone know there's a new site for questions on PICL and CCI. These are questions that I answer in writing. And what I'm trying to do here is to create a very large amount of online patient questions where there's questions and then answers in writing. Obviously, this format today is questions from patients and then a video format. Can also be listened to as a podcast, but this is more written, and this is the only site on Reddit that I can recommend at this point because it's the one I've got control over, and I can control the content here. There are a bunch of different Reddit threads on cervical instability, craniocervical instability, etc. And while there's some good information on some of those, there's some bad information on some of those as well. So if you're interested in submitting a question and getting a written answer, and also obviously having a resource where you can go, and there should be at some point hundreds of questions here you can search that have been answered by myself, then this is a good place to go. If you want a great place for Q&A among patients, meaning where I'm not allowed to go, which is also important, right? This allows patients to ask questions without, thinking that their doctor might see. This is a great resource here. The only one I can really recommend on Facebook because it's strictly controlled by some patients who really take a lot of time trying to make sure the information in this Facebook group is highly accurate. So just giving you some ideas there if you're looking for other places to get your questions answered, because remember, this is a weekly online session, but if at 2 in the morning you got a question and you're looking to get some answers, these are two great places you can go search the threads, either on Reddit or Facebook, and try to come up with some answers. So I see many CCI patients who claim to have migraine headaches, but really they have headaches due to craniocervical instability. This often happens, as I said before, because the patient views the term migraine as synonymous with headache, a little bit like Band-Aid has become synonymous with a bandage, right? We all know that a Band-Aid means bandage. It happens to be a brand. In this case, I think migraine in patient parlance has really become synonymous with any headache, but it's really not. Migraine is a specific type of headache involving a normal brain activity and vascular activity. It doesn't mean headache. It means a very specific kind of headache. And that's because there are many other types of headache as well. Cervicogenic headache, which is what we'll be talking about today, right? Where the neck is responsible for the headache. There are also cluster headaches, headaches that happen due to tumors, etc. So really migraine is not this garden variety term that means headache. And just because you saw a neurologist who told you might have migraines doesn't mean you have migraine headaches. And we'll go through that a little bit today. So what actually is a migraine headache? It involves brain hyperexcitability. It occurs through a specific cranial nerve brain pathway. It involves spreading through the brain that can be preceded by an aura, that should say preceded by an aura. So an aura might be some strange smell that happens and then the patient gets a headache, or some changes in the visual field and then the patient gets a headache. And it also involves vasodilatation, which is opening of blood vessels and too much blood flow in certain areas of the brain. So migraine symptoms, usually on one side, usually involves an aura, meaning something happens that precedes the headache. The pain tends to be pretty severe. So these aren't the kind of low-level nuisance headaches that, a lot of times patients can have. But these tend to be severe episodes, and they tend to be more episodic. Usually nausea and vomiting are common. You don't have to have nausea and vomiting, but it's common that migraine headache patients get nausea and vomiting. Usually there's a lot of sensitivity to light and sound, so patients getting a migraine headache like to just lock themselves in a room with that much sound and turn off the lights. There can be visual features like blurred vision, flashing lights are all common. And you can have dizziness, neck stiffness, fatigue, and confusion. Now here, I think sometimes this is where we start to see that regrettably many neurologists get on the migraine track and don't really ever consider the cervicogenic track. So I think some of these things in migraine descriptions happen because of that overlap, and that some of those patients being diagnosed by neurologists as having migraine actually have cervicogenic or headache pain coming from the neck. So how many migraine symptoms are also found in CCI patients? As you know, this is 101 patients that we queried about what their symptoms were after I had confirmed that they had craniocervical instability. The bigger the word, the more likely the symptom is happening. And this is in craniocervical instability patients. So I've outlined in red here all of the CCI symptoms that these patients reported that can also be found in migraine. So as you can see, there's no wonder that patients get confused between these two, because there can be overlap. And I don't think I even outlined all of them, because I'm just seeing a couple here like speech issues that can also happen in migraine. So how can you as a patient with headaches differentiate between these two? Because that's going to be pretty critical, right? If you have craniocervical instability and someone's treating you for migraines, you're not going to get better. If you have migraines and someone's treating you for craniocervical instability, you're not going to get better. So you've got to be on the right track to improve your situation, but oftentimes the medical care system isn't a big help there, because the medical care system has put you on the migraine track or the CCI track. So migraine, these are usually the differentiating things. Usually it has an aura, which is really not common in our CCI patients. So none of our CCI patients that I know of has a certain smell, for instance. and then gets a severe headache where they've got to lock themselves in a room. Another big thing, and this is one of the more common things I see, is that migraine is usually easily treated by specific medications that are focused on brain hyperexcitability or focused on vasodilatation. So for example, triptans have long been migraine specific medications that work really well in migraine headache patients, but they don't work really well in craniocervical instability patients. And I can't tell you how many CCI patients I've seen who have been put on triptans, they didn't work, and then they tried another migraine medication, and they just keep trying migraine medications because that's what the neurologist they're seeing does, but they're not really responding to any of those medications as if they were home runs, indicating that they probably don't have migraine headaches. Migraine is also not commonly associated with trauma or hEDS. Migraine headaches won't change if you move your head or neck around, or won't get better if you wear a neck collar or go see an upper cervical chiropractor. CCI, on the other hand, is usually caused by trauma or hEDS. There is abnormal movement-based imaging in CCI patients. A cervical collar generally tends to help these headaches. Upper cervical chiropractic generally tends to help those headaches. And there's usually some popping, clicking, or grinding in the upper neck, again, indicating that we're dealing with something in the neck that's causing headache. So in conclusion, the term migraine doesn't mean headache, but a very specific type of headache that involves abnormal brain activity and problems with the vasculature in the brain. It's really not that hard to differentiate between a migraine and CCI, but it happens all the time. These two get mixed up. And the treatment for these is completely different, right? Migraine is usually very responsive to medications, whereas CCI is usually not. Regrettably, if you don't get on the right pathway diagnostically, you're never really going to find success for your treatment, meaning CCI isn't treated with medications, and migraine isn't treated by tightening down ligaments. So you have to be on the right diagnostic path to get the right treatment. And then again, one more time, like, comment, share, and subscribe. If you joined in the middle, please make sure you do these things, because this is how these videos get out to more patients like you. And if you want to pay it forward in the CCI community, a good way to do that is to do these things so that the algorithm on YouTube and Facebook pushes this to the top when people start searching under migraine or CCI. Okay, so let me go to questions, because I'm sure we have a bunch. Let me stop sharing there. Bill, are there any CCI scenarios in which you tell a patient that PICL won't help and they need a fusion? Yeah, for sure. We've done that a good amount of time. For example, I'll just give you some examples off the top of my head. We've seen patients who have too much structural pressure on the brainstem, and it just doesn't make sense to do a PICL. Or we've seen patients who have too low a clivoaxial angle, and their diffusion tensor image shows that they do have some significant brainstem upper cervical spinal cord neural pathway disruption that is really going to need a neck fusion, or patients that are congenitally born with X and Y where it's just not compatible with doing a PICL, or patients that have too much bone spurring in the upper cervical spine that would prohibit us getting into the areas we need to inject with a needle because the bone spurs are blocking. So those would be some of the reasons why we don't go there with those patients. HRS. Doctor, I know dextrose injections contain dextrose in concentration greater than able to be found in the knee. Does post-injection the knee have more fluid to dilute normal levels, the more salt injected? Not sure I fully understand the question, but so I think what we're talking about here is hypertonic dextrose. Hypertonic dextrose means that it's just something that's more concentrated than the body's normal fluids. Anything, including dextrose, that is more concentrated than the body's fluids will draw water into itself. It will also cause a small amount of chemical microinjury, which is how prolotherapy works. And then that chemical microinjury to the local cells then causes a brief inflammatory healing reaction. If there is fluid in the knee, for example, whether you're injecting hypertonic dextrose, PRP, bone marrow concentrate, etc., you need to drain that fluid out because it will change the concentration of all of those things. So you do that before one of these injections. If you don't do that, then you're going to risk the injection not working at all because the concentration of what it is you're injecting is so different once it hits all that fluid. And more to this question, or can the cells of the synovium absorb the excess volume on their own? I think I answered that, but let me know if I did or didn't. Bill, how often do you see patients with an ADI 6 to 7? How dangerous is this typically? We don't often see patients in that category, but we have. So the first one of those many years ago that I remember seeing was a patient. We immediately sent the patient to a local neurosurgeon. The local neurosurgeon wasn't concerned. I was surprised by that. I would have thought that the local neurosurgeon would have gone immediately to a fusion. But the patient was kind of left hanging. So we said, okay, we'll try this. Let's do a transverse ligament. We'll hit the transverse ligament through a PICL. She did very well clinically. In addition, we got rid of most of that ADI. So that certainly showed me that this was something that we could treat for sure. And then since then, we've seen several and have treated those, and they've done well. So at the end of the day, my overall sense is that this is certainly treatable with something like a PICL. I do caution these patients, however, and sort of lay it out, meaning and say, listen, if you were to get into a big car crash, you could end up having an upper cervical cord injury because of the fact that this movement is so much. You could also end up obviously having a surgical complication because what's being planned surgically here is so much more invasive than what it is we're planning on doing. So really, all of this comes down to as long as the patient understands the risks and benefits of what it is they're doing, we go this direction now with these patients because of the good results we've seen and the fact that the neurosurgeons I've gotten involved have been under-impressed by the ADI, at least from a surgical fusion standpoint. In fact, we have one of these patients right now, and I went through this with her, kind of saying this is the risk and benefit of doing something like this, and you need to understand that. You're a big person. This has been explained to you in detail. You can make this decision if you want to try this or a surgical fusion. HRS, Doctor, how do Grand Cayman and Colorado compare in terms of cost for Genix, PRP, and SD, assuming same procedures? Assessment done in Colorado, one of the Colorado doctors at both sites. There's a big, well, I don't know the answer to that. There's a big difference in cost between Regenix C, meaning the culture expanded procedure, and being done down in Grand Cayman, and a same day procedure. Realize that we don't do much in the way of upper cervical treatments down in Grand Cayman because the infrastructure really isn't there if there would be some sort of complication or problem. As far as how PRP and SD compares between the sites, I'm not sure I can answer that one. I don't know explicitly the answer to that question. HRS, how frequently Dr. Marco Pitts travel down to Grand Cayman to treat patients? They are down there right now. I want to say every other month, every third month, something like that. But we usually have a patient down there a physician down there on a regular basis. HRS, doctor, can osteochondral defect in the knee present without any loose body? Can the body just absorb? It can. We've seen that quite a bit. Eventually, the cartilage does absorb or break up into tiny, small pieces that then get cordoned off into parts of the knee. Jessica, what part of CCI do you think makes you lose your range of motion? Jessica, I think that is due to two common things I see. One is certainly that the body starts detecting that range of motion can cause symptoms. So it starts limiting on its own the patient's range of motion, but also realize I think a lot of this is caused by patients, meaning that patients are concerned about moving their head or neck because it causes symptoms. They start wearing cervical collars. Certain providers tell them to wear cervical collars. For example, if I wanted to do posterior injections and put people on a cervical collar for a couple months, then I'm sure we could probably get some interesting results on reducing C1, C2 overhang. The problem is that I'm solving one problem and I'm causing another, right? Now you end up with someone with pretty much no neck range of motion. They're a non-functional human being after you're done treating them because they've lost all that range of motion, and it's going to take an act of God, meaning it's going to be very hard for them to get it back. So it's one of the reasons why I always tell patients cervical collar use should not ever be on an ongoing basis. It also shouldn't be used as part of a treatment plan. Bill, what are your thoughts on Dr. Gillette in Spain? I've got different thoughts about different providers, how aggressive they are, how likely they are to treat things that I don't think really need surgery, etc. I probably better to say that the two that I tend to see who fit my best sense of what surgeons are in this field and when they should get involved would be either Dr. Henderson or Dr. Patel. I think both of those physicians I've seen make calls that are very similar to calls we would make. They tend to be more conservative than not. I think Gillette tends to be more surgically aggressive than those two doctors. And so because of that, I haven't sent many patients to Dr. Gillette because, again, I think all of us physicians tend to try to find people at other specialties that kind of work with patients very similar to how we would work with patients. So I think those are the two doctors that I tend to refer to because they tend to be very conservative in how they would approach these patients. They don't really pull the trigger that often on surgery. And they tend to also tell it like it is, right? They're not trying to sell a bill of goods to somebody. They're saying, here's the advantages of fusing you. Here are the disadvantages of fusing you. I can't guarantee I'm going to make you better. AT, trying to be smarter, threading the needle. Sometimes after DNF work, anterior muscles, including SEM, go offline, and mild non-paresthesia follows. Communicative nerve issue, additional CCI. Probably not how you're describing it, but I do think that AT, threading the needle here, is something that you should consider, right? Meaning at the end of the day, if you're getting those sorts of symptoms that last for anything more than an hour or so, then you may be pushing it too hard. And in terms of threading the needle, you may need to back it off a little bit. HRS, doctor, is there any reason to treat an OCD lesion, a non-weight-bearing part of the knee, part of the cartilage that slides over the meniscus part, so understands and not wearing? Well, that sounds like a weight-bearing part of the knee. But again, a lot depends on what the knee looks like, right? At the end of the day, if we're talking about a knee that is old and already has a lot of degeneration, I could care less about an osteochondral lesion. It makes no difference at all. If we're talking about a relatively young person with an osteochondral lesion, and that's the only problem in the knee, then that might be a big deal. So it really depends on context. AT, so far with my CCI recovery, I felt a reduction of neurologic autonomic symptoms, but not the deep fascial issues yet. Typical muscle fascial issues resolved later on. That's a hard one to answer, AT. I don't know that I have a great answer for that right now. Because I don't have a great sense of what you mean by muscle fascial issues. So I'm not sure I can answer that one in the present moment. Jessica, do you think it's possible that DMX doesn't show the full instability like the muscles are guarding? Yeah, we've seen that, Jessica, for sure. Mostly where we tend to see it is in the atlantodental interspace. So I've seen several now where they look normal on the DMX, But then when we put the patient to sleep with slight forward flexion, the ADI will open up once those muscles have relaxed. We could also see that when the patient just doesn't get enough range of motion of the DMX. So that's why when we're comparing DMXs to try to get to apples comparisons, we want to see, for instance, on the C1, C2 overhang, the same amount of lateral bending. All too often, a patient's been told they had some treatment A or B, and they get second DMX and they don't go over as far. And it seems like the overhang looks better, but it's really the same if you were to push the patient that far. HRS, how many stem cells do you inject per injection? We're doing C procedures in an attempt to treat a small cartilage lesion. That information would be proprietary to the Cayman site, so I can't give you that info. But suffice it to say that it would be in the 10 to 7th range. Allison, Dr. Centeno, I'm planning on seeing a functional medicine provider in the near future. Is there anything you think they could offer that would help with CCI or PICL? I don't think a functional medicine provider is going to be able to help with CCI, meaning this is a mechanical problem. Now, where a functional medicine provider could provide some assistance might be in helping you clean up your diet, for example, lifestyle changes, other things that could help reduce chronic inflammation. But CCI is a biomechanical problem, which doesn't really lend itself to functional medicine very well. But what functional medicine can help with would be the overall systemic system. So I always like to tell patients, for example, for that chronic inflammation is kind of like a dry forest, right? If you've got a forest that's very dry, it's much more likely that a campfire can turn into a forest fire. But if you've got a forest that's very wet, like let's say in the Pacific Northwest, where it's constantly raining, things are constantly getting wet, the trees are very, very hydrated, there's not much dead wood around, then it's almost impossible for a campfire to turn into a forest fire. So that's kind of where I think functional medicine could help a lot, is recognizing that the more systemic inflammation you have in your body, the worse any problem you have that's biomechanical will be. So, for example, we know that patients that have disc herniations, if they don't have much systemic inflammation, those disc herniation symptoms last a couple of weeks. If they do, we're talking 6 months to a year to resolve. So that's really the area where I think functional medicine could be a big help. So are they going to be able to treat CCI? No, but they might be able to assist with some of the things that can make the CCI symptoms better. Natasha, can you please clarify what test would a doctor order or refer you to for Eagle syndrome, and if there's a CSF leak anywhere? Well, there aren't great tests for Eagle syndrome, regrettably, meaning that the standard test seems to be trying to look at if there's an elongated styloid. But as I've said before, elongated styloid processes are super common in the general population, and only about 6% of those have Eagle syndrome. So 94% of those patients do not have Eagle syndrome. So elongated styloid isn't going to cut it for Eagles. Or Eagle. Now, another thing that can be done is a CT venogram can be done, or an actual fluoroscopy-based venogram can be done. Sometimes that can be helpful in looking at whether or not there's pressure on the internal jugular vein and the associated nerves. But again, a relatively high percentage of patients, as much as 1 in 3 to 1 in 5, will have anything from moderate to severe stenosis and no symptoms. So again, not a great test for Eagle. So Eagle ultimately comes down to a clinical diagnosis combined with those other tests, and there's a good amount of fudge factor in there and trying to figure out whether this, what I'm seeing on these images is causing this person's symptoms. Remember, we talked about in one of these types of Facebook Lives, we talked about, do you have Eagle or CCI? As far as on the Eagle side, it would usually be pain at the back of the throat and those sorts of things, because that's going to be ninth cranial nerve compression. And then CSF leaks are also very difficult to diagnose via imaging, meaning that you can try to get MRIs that are either stir or heavily T2 weighted that show fluid collection better. But as to what's normal and what's being caused by a CSF leak, there's not a fantastic distinction there. Oftentimes, there's a lot of room for doctor judgment, meaning there's very few smoking gun images that come out of those studies. You can also do things like cisternograms, where you inject a radionucleotide into the dural space, and you look for it to leak out over time. So it's kind of like an all-day test. So you keep taking serial pictures. But again, sometimes you can get a smoking gun there, but if you have a very slow leak, which many of these are, it isn't likely that you're going to get a smoking gun image. So realize that for both of these diagnoses, you're really left with some imaging evidence and then heavy dose of clinical judgment to decide if you're treating the right thing as the doctor or the patient. And I know that's hard for patients to hear, because patients want to believe very firmly that they can go into a doctor, get some test, and that test will very clearly show whether they have X or Y. Regrettably, often in medicine, that's not the case. So be really, really careful with both of these diagnoses, because as we know, both these diagnoses heavily overlap with craniocervical instability. They overlap with other diagnoses as well. So operating on someone who you think is a CSF leak, but really doesn't, is going to help that person. Operating on someone who you think has Eagle syndrome, but really doesn't, isn't going to help that person. Jessica, typical PICL procedure, how long does it take? What about just posteriors? Not sure what you mean by just posteriors, but as far as how long it takes, a PICL procedure comes in 3 parts, let's say 4 parts really. First part's going to be 5 parts. First part's going to be a telemedicine. Second part's going to be about 40-minute follow-up after that telemedicine for a pretty thorough hands-on exam. The third part's going to be a bone marrow aspiration procedure, then recovery. The fourth part is going to be the PICL procedure. And then the fifth part is going to be more protracted recovery, meaning time in PICU after the procedure, more like an hour. Could be an hour and a half for some patients, could be 35 minutes for others. So if you look at all that, that's an all-day procedure. And I want to give a big shout out, by the way, to our patients from Germany. I have been blown away by how quickly Germans recover. I think I have a big enough N now to know that this is a thing, meaning I'm witnessing, I think, a very big cultural difference between German patients and other patients. But the first German patient I ever saw, by the time I tried to get into the PICU to see the patient, usually between the next patient I'm seeing, that patient was out the door. I was like, wow, that was quick. And then it kept happening. So it seems to be a thing. I don't know why. But Germans are incredibly fast with recovery. So a big shout out to our German patients, because I have been nothing but impressed with how quickly Germans recover. So for a German patient, 30 minutes of recovery. Everyone else, let's say an hour. Posterior injections can have the same couple different parts and pieces. So for posterior injections, there will be that same follow-up. Oftentimes a telemedicine follow-up, a little different, not a bone marrow, usually just a blood-based PRP procedure, But if there is a bone marrow posterior, then it will have bone marrow aspiration. And then those other two parts I talked about, the actual injection procedure and then recovery again. For posteriors, I would say they generally take about 60% of the amount of time that a PICL would take. And as I've just described it, a PICL is really going to be an all-day affair for that patient. Bill, ever since my neck injury, I will occasionally wake up at night feeling confused, no other symptoms, goes away after going back to sleep. I believe called sleep drunk. Do you see this often? Not that often, no. Some of the things to consider there could be whether or not there could be some backup at the internal jugular vein because you're sleeping with your head turned. That's one thing. I have heard that. Another thing to consider might be whether there are other vascular things happening at night. Obviously, you'd want to make sure that you saw a neurologist, a vascular cardiologist, et cetera, just to rule out that there's other things that are happening that could be causing that confusion outside of your neck. WII or Wizard. If I'm holding an AO adjustment for more than a month and still have symptoms, could a PICL still help me? My understanding is PICL is like glue to keep the atlas in place. It depends on what we're treating there, meaning that you might need an upper cervical procedure. So let's say you're fully stable, right? Then you don't have craniocervical instability. Then you probably have craniocervical syndrome, and that means that there's something in your upper neck which is causing these symptoms. And so that could be the case with what you're describing, which would mean that those upper neck structures need to be treated, not necessarily the instability component. Raj, hi, doctor. Do you know much about IIH, is CCI a cause, or it's more of a cardiovascular anemia cause? So intracranial hypertension transiently can be caused by CCI. So that would be that there's instability caused with neck movement, where the transverse process of C1 is putting pressure on the internal jugular vein, and you can get some backup, which we would call intracranial hypertension. Now, idiopathic intracranial hypertension means that the person that diagnosed it didn't know what was causing it. In that case, we do know what's causing it. So CCI can cause increased intracranial hypertension. It's not idiopathic. Idiopathic means that we don't know what's causing it. In that case, it would be CCI caused increased internal intracranial pressure. HRS, what is your opinion on ITRT Spain? The main doctor was at some IOF conference recently. I don't know who that is. They inject 40 million cells every treatment and shown awesome cartilage regeneration. Large hole on MRI. I don't know that place at all, ITRT Spain. I don't know who that is, so I don't really have an opinion. Sonia, hi, Dr. Centeno, how much reduction in lateral overhang on DMX might you expect to see? 7 months PICL1 before proceeding with the second procedure. I don't think there's a specific amount that we'd expect to see. Our main focus is going to be change in symptoms. Now, we can use DMX after the fact in order to see if that person is on the right track, right? So we can use a DMX to, let's say a patient hasn't seen any change in symptoms, and we want to know that we're heading in the right direction. Then we can use a DMX to try to see if there's a reduction. In general, what I think I see is in most patients who don't have hEDS, we're seeing about a 25% decrease with each one, somewhere in there, sometimes as much as a third. But again, we're not routinely retaking DMXs because it's a higher radiation exposure. And for a lot of our patients, that's a non-starter. I know patients, it seems like patients in the CCI community break into two sides there. One would be like, I don't want the additional radiation exposure unless I absolutely need it. Other one's not as sensitive on that issue. But for a lot of our patients, redoing the DMX, we would only do, because of those types of things and concerns, if there was a real need to try to see what's going on. Christy, I have 3 types: classic migraine with aura, vestibular migraine, and CCI tension headaches that start from my neck and travel up the back of my head, get migraine, and keep triptans with me. Yeah, so Christy, it is possible that there are different kinds of headaches that are there. Vestibular migraine really isn't a thing here, meaning that vestibular migraine is kind of a junk term, in my opinion, used by neurologists when they see a headache associated with dizziness. Since we know that those dizziness type headaches are almost always coming from the upper neck, then that's just a cervicogenic headache. So I think that's more of a junk term. CCI tension headaches, again, we're going to put those last 2 into cervicogenic headache, meaning headaches coming from your neck. And then the first one certainly could be more of a traditional migraine type headache if it's triptan responsive or triptan responsive. HRS, Dr. You attempt to treat mild scoliosis sideways or only reserved for severe curves with considerable pain? Yeah, only reserved for patients that are clearly having symptoms due to scoliosis. Jessica, can CCI make other cervical vertebra unstable, or was it likely it always there too? I don't think CCI can make other vertebra unstable. It's more likely that whatever injury caused the CCI or whatever mechanism caused the CCI, that that's also causing instability at other sites. So that's usually what's happening. It's been advanced by John. If PRP is better than Prolo and STEM is better even than PRP, would you say PRP is 10x what Prolo is? No, I think I would say, as I've described this before, John, there are some different things we're talking about here. But if we look at, let's say, SI joint instability in women, right? If we're going to do Prolo, it's 6 to 8 visits. If we're going to PRP, it's usually half of that. So 3 to 4 visits. If it's bone marrow concentrate, usually 1 to 2 visits. So there's no 10x in there at all. Maybe 2x might be a thing. And I did want to get over, before we get too many more questions in, I did want to get over and answer some of the questions from Reddit. I've already answered them in writing, but give more of a narrative there. Well, for some reason it's not letting me do that. Let's see if this is it. Here we are. Okay. Okay, I promised some of the Reddit people that I'd get some answers in on these. Matt, on the Reddit PICL, there's a lot of focus on rehabilitating the suboccipitals, but not really the longus coli. Why is this? So really what Matt's talking about is that you've got muscles in the back, suboccipitals, you've got muscles in the front, longus coli and capitis. The laser exercises focus more on the back suboccipitals, but they would also focus on longus capitis. The longus coli, the one that goes fully up and down the front, that would be more deep neck flexor exercises. And that's discussed in some of the new rehab videos that are coming out on December 28th. Just to remind everyone, on YouTube, those were released on December 28th. There's like 10 of them. They'll be coming out once a day on December 28th. So keep an eye out for that. But the reason why there's been an emphasis on the laser exercises, those are easy to instruct patients how to do. Deep neck flexor exercises, you really need a physical therapist to help you with. So as far as home stuff goes, that's more difficult to do. And then C-Magic here, I know headaches is one of the top symptoms of CCI. Is constant pain at the base of the skull considered a headache? Yeah, so as I talk about here, that pain at the back of the skull is considered an occipital headache. So that's what's happening. So I did promise some people over here on Reddit that I would answer some of their questions. Again, this is this PICL Reddit thread that I started. Put a plug in for that if you want to get questions answered. It's a great place for you to get those questions answered. Lots and lots of them over here. You can also come over here to try to find things I've answered in the past. So let me cancel out of there. And we'll go back here. Is there a strong correlation with holding AO, NUCA, and CCI, of holding for longer durations as post-PICLs provide post-procedure feedback that the PICL is doing its job? I think it does. That makes sense to me. Now, may not always, but that makes sense to me. Submit advance by John. Can you share more patient success stories like you did a few weeks ago? Yeah, John, I have about a dozen in the queue. I think what I might start doing, regrettably, there always seems to be some other thing I have to do but that. So I think what I might start doing is just start when I'm in clinic doing some little videos where I'm describing that patient because there isn't a clinic that I do and I see PICL or CCI patients 3 days a week now where there isn't some great story to tell. So I think just to get them recorded, I think that's what I'm going to do. I'm going to go down to my office while I'm waiting for something to happen. Just record a nice little 2-minute video summarizing that person and what's going on for that person and get those out there that way. Just do them on my phone because if it requires me to put together a bigger video with all the other stuff I'm doing, as you guys know, I spent a lot of time doing things for the CCI community. I do these. I've just put together a presentation for this. I've now got the PICL thing I'm answering on Reddit. I'm answering probably, I would say, some weeks close to 100 patient emails a week. So I think I will start doing that as a way to get those out there. And I think that'll also be more natural. You'll see those as they flow through my clinic day. And I cannot pronounce this first name for the life of me. I apologize. So I'm not even going to try. I live in Europe. I would like to get an online consultation with you. Is it best to go through Regenexx Colorado, or should I do something else? Yeah, you would go through Centeno-Schultz Clinic in Colorado. So that's through ISIS, ISIS. I'll also put my email address, which I do a lot here. Centeno office at centeno-schultz.com. So, okay. So I just put that in there. You can also reach out to me directly via email. I'll hook you up with the right person. So 2 different ways to do it. One is just to go through Centeno-Schultz Clinic in Colorado. The other is just pop me an email. I'll hook you up with ISIS and she can figure it out. You and her can figure it out from there. Submitted in advance by John Gardner. How long should someone wait to go for a run after a PICL? That's really going to depend on that person. If you're running before and that doesn't aggravate things, then you would wait until the flare-up from the procedure dies down. And once that's died down, then you can start to go back to what you would normally do, including light running. HRS, I read in a study that cartilage lesions with underlying bone exposed in one compartment can cause osteophytes in a different compartment. Osteophytes are caused by instability. So I think what they're saying is that if you have a bone lesion in one compartment due to instability, then you can get osteophytes or bone spurs forming elsewhere. But the bone spurs are not forming because of the cartilage lesion. They're just another feature of instability, like the cartilage lesion is a feature of instability. Debayan, I've heard that post-PICL around 3 to 6 weeks, patient feels worse before they get better, and shorter the duration of ailment. Usually it's one and done. How long does autonomic symptoms take to go? I haven't really seen that Debayan at all as a thing. So one of the things you have to be careful of in social media, right, is that the loudest voices tend to get noticed the most. But there are many, many patients. For every one person, talking about X, and that's been my experience, there's 10 back here who won't comment at all on what their experience has been. So long story short is that's not a thing as I see it at all. Usually what we see is that in about half of our patients, there'll be a honeymoon effect. And that honeymoon effect can last for a couple of weeks. So I think what those patients might be trying to explain, and this is only about half of our patients, is that they felt better for that first couple of weeks because things were tighter and swollen. And then when that swelling goes away, things kind of just go back to what they usually are. And they're concerned because they felt better for the first couple of weeks after the procedure because of that artificial tightness from inflammation. Then the inflammation goes down. All of a sudden, they're back to what it was prior to the procedure. So like, what's going on? And then your second question with regard to shorter duration of symptoms. Yeah, so that's 12 to 18 months from injury. Those patients are usually a single one and done. And then how long does autonomic symptoms take to go? Nothing special there. They would go along the same lines as any other symptom. Jessica, for fusion patients, your opinion, would you start with just a C1C2 fusion and include C0 if needed? Yeah, so C1C2 is going to be a massive overloader of everything above and below. So there probably isn't any fusion of the neck you can get that would take away so much range of motion in one fell swoop, because C1C2 is 50% of your neck rotation. So every other level doesn't have that much movement. C1C2 is the most mobile level. So if you were to fuse the most mobile level, then you're going to get adjacent segment disease, almost predictably, above at C0, C1, and below at C2-3, C3-4. So should you include the skull when fusing? Probably not. Again, it really depends on the patient, right? Is C0, C1 unstable? If C0, C1 is unstable and you failed all conservative measures, including something like a legit PICL, we're not talking about some bootleg procedure in Europe or India or wherever, but we're talking about legit one done in Colorado, then you would say if 0-1 is unstable, it needs to be fused. If 1-2 is unstable, it needs to be fused, et cetera, et cetera. So unstable levels in that particular case where a person has failed all conservative care need to be fused. It's been advanced by Harry Winston, is expected for the frequency of migraines to increase with time. Over time with CCI, I used to get 2 or 3 a year, now I get 2 or 3 a week. If you're getting headaches with CCI, you don't have migraines, which was kind of the purpose of the talk, right? Migraines are a very specific kind of headache. Migraine does not mean headache. So it's a very important thing for patients to understand. When you go into a doctor and say you have a migraine, that's a very different thing than going to a doctor and saying you have a headache. And I think that's what's happening here. Harry, you're convincing or conflating those two terms that mean something totally different. Migraine as a term to a doctor doesn't mean a headache. It means a very specific kind of headache. Cervicogenic headache is really what I think you're talking about. Zigzags, a possibly get a stroke from incorrect PRP directions, the elbow, wrist, or shoulder. That would be pretty tough to do. Anything is possible, but I would say that would be extremely, extremely unlikely in the order of getting struck by lightning. So that would be something that probably, if there's two things happening there, they're probably happening independently and one has nothing to do with the other. HRS, doctor, how do you ensure that you don't enter the SI joint during a bone marrow aspiration? Yeah, that's why we would use guidance, whether that guidance is fluoroscopy or ultrasound, usually ultrasound, to make sure that that's not happening. HFBHJ, I know the patients that come early enough need 1 to 2 PICLs. How about posterior P for patients that come early and only have damaged posterior? Similar thing. Yeah, probably similar, very similar. If you're early in the game, you're going to need less treatment. If you're later in the game, you're going to need more treatment. It's no different. Same thing in medicine that happens, right? If you wait and come late after cancer has metastasized, very hard to treat it. If you catch it early, very easy to treat. And that's a common theme throughout medicine and multiple diagnoses, including this one. Bill, can bodily inflammation get worse in winter, especially with EDS and other disorders related to CCI? I don't think it's really related to winter or summer. It could be that patients are less active in the winter, and hence that causes more inflammation, meaning that you should have a strategy for being as active in the winter as you are in the summer. HRS, doctor, how good is healing post-core decompression for osteonecrosis? Both of the lesion to be treated itself and lesions caused by drilling of the needle. I don't know what you mean by how good is healing, meaning if you catch, for instance, hip osteonecrosis and Arco grade 1 or 2, you've got about an 80% cure rate. If you wait till it's Arco grade 3, about a 60% cure rate. If you wait till Arco grade 4, about a 40% cure rate, for example. Zigzag, how do you treat biceps tendon subluxation at the shoulder? Usually there'd be no reason to treat it, but if we did need to treat it, it would be by treating the transverse humeral ligament, which is what usually holds the biceps tendon in place, and also working on the postural position of the shoulder, because when the shoulder is like this, which is super common in patients that do this all day, right? Then that's going to cause biceps subluxation. Usually there's no reason to treat it, but if you did, those are the things that you would be looking at. Lanaya, hey, Dr. C, I've rotated C1, C2. I've had a bad AO experience in the past, and I'm nervous treating chiropractic again. Do you have any recommendations in between PICLs? Yeah, as I often say, I don't know that I would start an AO relationship in between PICLs until things have healed. Usually we want patients who have had successful AO or NUCA experiences prior to continue that type of care. Starting it in the middle is a little rougher. So I'm not quite sure what to tell you there. One of the things that you might consider is seeing Scott Rosa in New York, upstate New York. In our experience, Scott's kind of the AO NUCA whisperer. He really is able to take what he sees on his more advanced imaging based on his extensive experience and then relay vectors to other upper cervical chiropractors, and we've seen great success with that. Daniel, is unilateral PICL still a little cheaper than a both side injection? It was a little cheaper a couple of years ago. No, there's no difference. We're treating both sides these days anyway, regardless. So we don't, I don't know that I've done a unilateral PICL ever. Maybe someone else was in the office, but that's not how it's done at this point. Daniel, I have jerks that make my head turn fast, like muscle spasm, C1, C2. What's that? Yeah, Daniel, I probably need to see it to get a better idea. We certainly have seen CCI patients that have myoclonic jerking, mostly due to the instability. But I'd need to see what it is you're describing to better tell you what it could be related to. HFBHJ, how is the PAOM treated and what's typically used? It's slightly deeper than nuchal. Can laxity cause a heavy head feeling? PAOM is often treated with bone marrow concentrate. It's an X-ray guided procedure simply because it's a very deep structure that's invested with the dura between the skull and C1. And that's how it's treated. Can laxity in it cause a heavy head feeling? It could. But usually a heavy head feeling would be due to weakness and atrophy in the suboccipital muscles. William, how much risk is involved with a patient with an ADI of 6'7" getting a DMX, and it has to be done regardless? Shouldn't be a lot of risk if it's 6 to 7 millimeters, meaning that 6, 7 millimeters would not be enough to, in most patients, to cause an encroachment of the dens in a bad way, meaning in a permanent injury way, certainly you'd want to let that person doing the DMX know what's going on, so that if they can get a lot of ADI opening by just doing a small amount of flexion, that might be something where they just sort of call it good there. So it'd be good to communicate that. Stacy, what would you say about severe headache preceded by an aura in a person diagnosed with POTS, dysautonomia, doesn't respond to triptans, symptoms are severe headache accompanied by prolonged muscle spasms, spasm maybe in the right arm, the right hand is completely locked up, nausea and vomiting. Probably not migraine. It sounds like a musculoskeletal headache to me, more so than a migraine because it's not responsive to triptans. It involves spasms, meaning that's going to be biomechanical. The right hand arm could just be thoracic outlet syndrome getting irritated. Daniel, I have a muscle spasm in CCJ area. Yeah, I think I got that. Stefan, I was familiar with it before the stem cell treatment. I used to suffer from severe headaches. So it was either right or left side. I also have migraines with aura, sometimes even weekly. One wrong move or too much stress and suddenly migraine was there until I went to chiropractic stem cell treatment. So the headaches were the first to disappear. Yeah, gotcha, Stefan. Thanks for saying that. I think what you're describing again is you have cervicogenic headache coming from the neck, and we treated the neck, and obviously that headache got better. I would say headaches are one of the easier things that we treat in the world of symptoms that revolve around CCI. So thank you for posting that. Christy, how do you gain back lost range of motion? Does this just happen with healing after BSL? No, Christy, this is one of the reasons why I tell patients stop it with this whole thing where you don't turn your head. I've seen more damage caused to patients by patients being told not to turn their head, or patients being afraid to turn their head, or patients wearing a cervical collar, so they never turn their head. It takes, like I said, it takes an act of God. And what I mean by that as a doctor is act of God things are things that only happen with an immense amount of patient effort. So if you want to restore normal range of motion after someone hasn't moved their head for 3 years and all they get is this or this, I can get a little bit of that back, maybe a third of it by treating their upper neck, but the rest of it, it's going to be years of hard work, meaning it's not just going to come back very easily. So this is one of those areas where I tell patients, do not stop turning your head. Patients do this all the time. Like, well, if I turn my head, it goes out and I get symptoms. I understand that. But unless you're getting normal range of motion every day in that head, even if it's slow and controlled on your terms, you're going to be creating a new set of problems that are very, very difficult to treat. HFB, HJ, how many prolotherapy treatments are needed for mild nuchal ligament laxity? Probably just 1 or 2, but I don't know that that's what you really have, meaning that you might have lots of other things going on. I don't know that mild nuchal ligament laxity is even a diagnosis that ever gets made, meaning that there is no specific set of motions you would see on a movement-based image that would allow you to say, aha, it's just the nuchal ligament. So be a little careful. That sounds a little fishy to me as a diagnosis. Eva, between CCI and 6-7 bulge, which can create widespread myelopathic burning, pain, including arms and legs. Both of them can. 6-7 bulge would be target number 1. And the CCI would be right up there as well, meaning that we see patients without disc bulges who have CCI who get what you're reporting. We certainly see patients with just C6, 6-7 disc bulges without CCI who get what you're reporting. And we see patients that have both. So the bottom line is anyone that is treating your CCI needs to treat the 6-7 bulge at the same time, which is typically what we would do. Kimmy, I've had 24/7 migraine right after injury that nothing made better, always left-sided, always followed the occipital nerves. Triptans would give me relief 9 days a month because that's all insurance would cover. AO and my first PSL took the migraines down significantly. I only get them a couple times a month, and they're 5-7 days and always, rather than maybe always a 10. Oh, thanks, Kimmy, for reporting that. Yes, like I said, Cervicogenic headaches are relatively easy to treat once you figure out the source, and they often get conflated with migraines. So again, you can't treat cervicogenic headaches with medications and have that fix it, but you can fix cervicogenic headaches by injecting the neck. Stacy, I'm starting to have swallowing issues, feeling like something is sticking in my throat. I was eating dinner and a food bolus caught in my throat for a minute. I couldn't swallow at all. This is new symptoms. Can this develop suddenly? It was typically a brain fog, dizziness, head swimming. I'm doing PT right now. I have pain at C2, getting DMX done soon. Yeah, so Stacy, throat issues are not uncommon in patients that have CCI. So that certainly could be a CCI-related issue. It obviously might be due to something else. So it's definitely something to get looked into, both by other doctors just to make sure it's not something like a tumor, et cetera, but also by a doctor who knows a lot about treating CCI so that that doctor can say, okay, well, this makes sense for you. Haley, does presence of a tethered cord impact CCI treatment plan and ability to experience improvements or intervention like a PICL? Yeah, Haley, be really careful there. Again, a cold tethered cord is way, way, way overdiagnosed, meaning that just because you've got a woman who is having a little bit of urinary incontinence, especially a middle-aged woman or older, or urinary symptoms, doesn't mean that they have a cold tethered cord. Back pain, and many of our female back pain patients get issues related to those that have nothing to do with an occult tethered cord. So again, we're not talking about a tethered cord, we're talking about an occult tethered cord. If you have an occult tethered cord, it would be only because you've got a type 1A or low clavoaxial angle type CCI. It's not something that's going to occur in other types of CCI. So the first thing I would say is you probably don't have a occult tethered cord, even though you've probably been told that you do. More likely, you've got issues related to a separate back problem that can be easily treated, having nothing to do with detethering your cord. So be very, very careful with that diagnosis, because I've seen a lot of patients get neurosurgery based on, quote, occult tethered cord. They either got much, much worse, or now they've got a complication from the neurosurgery, and they never really had a occult tethered cord. They just had, it was on only someone's opinion that they did. Natasha Love, Analogy Pacific Northwest, forest fire and chronic inflammation. Yeah, that's true, Natasha. If you've ever been to Pacific Northwest, as you can see, if you're in a really wet part of that area, they don't get many forest fires because it's just not possible. Olivia, yes, and IJV can cause confusion. I wake up terribly confused every time I sit on my side. Gotcha. How does this relate to POTS? CCI relates to POTS through likely irritation of the vagus nerve. So that's what we're talking about. For the patient I was talking about emailing me, this is my email address there. And I think we're starting to get to the end of questions here, maybe. What was the PICL Reddit group name? It is right here. So it's r/PICL. So it's /PICL on Reddit. I'll keep that up while I answer some more questions here. If I was doing laser exercises for the month prior to the PICL, when should I start them again? Following the procedure, as soon as things return back to their normal post-procedural status. So, for example, let's say you start here and you get a post-procedural flare, and then a week later you're back to there. Once you're back to there is when you would go back to those exercises. Regenerative medicine channel, do you think it makes sense to do NUCA and curve correction at the same time? I'm pretty far along, 2 PICL, 2 PRPs, wondering if it's too big or... Yeah, I think you'd want to do one of those at a time, make sure it was right for you, and then you could certainly do curve correction while you're doing NUCA, assuming you can tolerate it. But I think you would sequence those. Debayan, doctor, have you ever tried PRP instead of bone marrow during early days of PICL? No, always bone marrow. That's not going to change. Nausea nuca mandatory after PICL or ligaments just pulls. Not mandatory after PICL. Blake, hi, is it normal to feel looser than before after the prolotherapy formation phase wears away? You shouldn't feel looser than before. This came up recently in a patient question on the PICL group, where we had someone sequence, a physician out there sequencing PRP injections into the ligaments every 3 weeks. And the patient felt like they were going backwards, getting looser and looser. And my concern is that that's too close together. There are phases of healing after these injections. And the problem was that doing that close together could cause more damage and not enough time for healing. And so I think, Blake, if you're getting these in rapid succession, that could be the problem. Elias, Dr. Stan, have you ever heard PICL? No, never had the PICL performed on me. Now, the interesting thing is I don't have craniocervical instability, so I wouldn't want to do that, obviously. But we have done it on numerous physicians. And I think I've told the story before. Those physicians, because they knew about CCI, picked up pretty early that they had CCI, much earlier than we normally see. So they got treated within months of their car crashes in this case. And both of them were a single procedure and done, and never had a problem since. So it was a great testimony about what happens when someone rapidly picks up that they have this issue because they get to the right doctor. In that case, the right doctor was themselves, right? They were like, I think I have CCI, and then reached out to me. AT, is there any possibility of bite issue causing subsequent muscle issues, and more likely the other way around, usually the other way around? Okay, I'm only going to take 2 more questions because we're already 12 minutes over, but I really appreciate it. There's lots of great questions today. Elias, so I had pretty severe CCI. I had a 5 millimeter overhang on each side. I had posterior PRP from Dr. Silva out in Bellevue, and that saw significant improvements with pain neurologic symptoms decreasing. I was bedridden all October, leading up to PRP in November. I'm already 8% better on week 6. Should I continue posterior bone marrow, or I go PICL to get 100% better? So the question I think would be is, how much instability do you still have, right? So for example, C1, C2 instability would cause the C1, C2 facet joint to get pissed off. A PRP injection into the C1, C2 facet joint could make that feel much better, but the instability remains. So the wear and tear on the C1, C2 facet joint could remain. So I think if I were you, I'd probably repeat the DMX, going to this exact same amount of lateral bending as the first one. And if you still have instability, then you probably need a PICL. If for some reason the instability has gone down and you're, again, getting the same amount of lateral bending, apples to apples comparison between the first and second DMX, then I'd probably just stay the course on what it is you're doing. Blake, how often should dextrose prolotherapy be used? Dextrose prolotherapy is a nice way to tighten ligaments in the right patients. I think it should be used widely and often. There are times when it's more efficient to do PRP or bone marrow because there's just too much instability. But dextrose prolotherapy remains a really nice technique in order to get things to tighten down, and it's very inexpensive, so it's helpful from that perspective. Okay, guys, wonderful questions. We're about 15 minutes over, but I wanted to stay in and try to get these questions answered. Remember, there's this RPICL group. Also, don't forget Dan Semrad and his colleagues on Facebook. Let me switch over here. Hold on a second here. Let me stop sharing there. Go to that one there. Run this Facebook group, craniocervical instability, PICL procedure. That's a great place for patients to go where they want to say things about the PICL, about CCI, about our clinic, whatever, that they don't want a doctor looking at them. And so it's a safe space for patients. And also sometimes patients want to be able to have conversations about the doctor. Sometimes they want to have conversations about things that maybe the doctor doesn't know about, or whatever that is. This is a great place because it's patient-to-patient communication, but is still strictly monitored by excellent leads, including Dan Semrad and his colleagues, to make sure that the information you're getting there isn't wacko. So that's another great place to go and consider joining up and reading all the threads. Well, thank you so much for watching. Let's see, next week is going to be when? Think about this. It'll be on the 29th. So yeah, I'll be here on the 29th. We'll do another one of these on December 29th on another topic. So I appreciate all the great questions. Again, as I always say, this is how patients learn, by getting questions answered. If you haven't considered doing this in a podcast format, we're actually going to rip these to podcasts here pretty soon. But, you know, I also do a lot of podcast listening to Facebook channels. They're not really podcasts, and I'm probably yanking down a lot of 5G bandwidth while I'm doing it, but it's kind of nice too, because, you know, this is the kind of thing that lends itself to a podcast, just sort of listening to the Q&A if you're trying to learn about a subject. So we'll be doing that soon as well. So thanks so much for watching. Have a great week. Have a wonderful holiday, a wonderful Christmas, a wonderful whatever it is you celebrate. And we'll see you back in a week. Same bat time, same bat channel. Thanks so much.